Calling us via the web from all over the world. And as you know, we have entered a new era of global communication on this type of event, and probably is like to become a standard in the near future. The topic of the presentation is the laparoscopic robotic sacrocolpopexy for the management of pelvic organ prolapse. These are my disclosures. This is a typical severe patient with three-compartmental pelvic organ prolapse. The question is, laparoscopy or robotics are appropriate techniques in the management of three-compartmental prolapse? The answer is yes. The world scenarios of POP repair is traditionally urologists, they approach with a sacrocolpopexy, the gynecologists with vaginal surgery, the urogynecologists with a transvaginal surgery, and the laparoscopists, both urologists as gynecologists with the sacrocolpopexy. So the sacrocolpopexy, is it a fashion or it will become the new gold standard fashion? Where we started from? This is one sentence from a patient that was very, very disappointed from a recurrence, or very prolapse, but when she has a mesh complication, she is very angry. And this is one of the severe case of a disaster of the transvaginal mesh repair with a complete procedentia and complete erosion of the vaginal wall. And this is induced the FDA in 2001 to publish a warning on a reclassification of the surgical kit for mesh repair from class type 2 to type 3, just considering all the side effects and the potential unreasonable risk of illness or injury. And they require to the company to have a randomized clinical study, compare the native tissue repair versus the mesh repair. And you see at the mid-long-term follow-up, there was no statistical significant difference. That's induced the FDA in last year, in April 16, to ban completely in US market all the mesh for the transvaginal repair. So there was a complete, an increase, a tremendous increase toward the sacrocolpopexy for the POP surgery compared to the transvaginal surgery. These are the techniques for the laparoscopic restore for the suspension of apical vault with the level 1 according to the Lancy levels, with 4 with mesh, laparoscopic sacrocolpopexy, lateral suspension, pectopexy, or robotic sacrocolpopexy, and 1 with the native tissue with the uterus sacral ligament suspension. This is the conventional approach of the max vaginal fixation with a mesh that is anchored to the longitudinal ligament, anchoring the apex of the vagina and the anterior and posterior vaginal wall. There are some difference and some option. One is the French approach, in which they fixed the mesh not directly to the vaginal fascia, but laterally to the fascia of the levator and eye muscle. And this is our preferred approach in our experience. These are some of the clinical outcomes of the laparoscopic sacrocolpopexy. And I want to share with you, first of all, that actually there are more than 8,000 people published in the literature with more than 10-year follow-up. So it's the long-term follow-up, and the more successful procedure has been reported in the literature. You see, is the number of patients more than 1,200 people with more than 2 years, with excellent result, 91 with objective and 92 subjective success rate. And also recently has been published in Neurourology Urodynamics this year, what's happened about the lower urinary tract function after laparoscopic sacrocolpopexy, and mainly in a frail group of patients, the elderly patient with severe pelvic organ prolapse. And you see there is no difference all, there is an improve on urethral function as well as in bladder function and in avoiding efficiency. So it's really a very good procedure. But who is the ideal candidate for laparoscopic robotic sacrocolpopexy? Obviously is a symptomatic patient with a stage 2 or more, with a significant apical component with advanced anterior vaginal wall prolapse or three-compartmental prolapse, or in case of recurrence, with an expanding indication of high degree cystocele, paravaginal defect repair, or high degree rectocele and enterocele, and in a young patient desiring vaginal depth for sexual function, because with the total vaginal length was significantly reduced in the vaginal group. And this is a very impressive drawing in which you see there is a comparison between the vaginal approach that leave the length of the vagina 10.2 centimeter versus 12.9 centimeter in the abdominal approach. So the sacrocolpopexy has the highest success rate of anything we offer with the grade of evidence 1, level 2 or 3 that show comparability of laparoscopic to open sacrocolpopexy. The success rate that ranges from 78 to 200%, with a level 1 evidence that sacrocolpopexy has superior anatomical outcomes respect to the sacrospinal ligament suspension, and sacrocolpopexy remain the gold standard procedure for apical prolapse. But there is not only light, but also some shadow, in which this is a very interesting study with the MRI, compare the vaginal axis with the different procedure, like compared to the traditional one. You see the normal vaginal axis is like a banana shape, and with the sacrocolpopexy, we have the verticalization of the axis of the vagina, while with the sacrospinal, we have the downward of the posterior fornix. This is a paper published by our group on a cadaveric study in which demonstrated before and after a laparoscopic colpopexy. You see there is a verticalization of the axis of the vagina. But now there is an emerging concept of nerve-sparing laparoscopic sacrocolpopexy, because you see there is the hypogastric nerve, the pelvic plexus, that can be interfered during the surgical dissection. One of them is the superior hypogastric plexus, and there is a risk of lesion during the exposure of the anterior longitudinal ligament, as well as the risk of lesion for the hypogastric nerves during the creation of the retroperitoneal tunnel of the mesh for sacrocolpopexy. This is an example of what I'm saying about the nerve sparing that you see. This is the opening of the peritoneum, and you see there is the right ureters, and it should be very careful, because immediately parallel and to the right common iliac artery, 30 millimeter above the sacral promontory, because there is the presacral fascia that is extremely important in concept of the nerve sparing. And it's really important in this maneuver. You can see also the middle vein, sacral vein is visible. And sorry. And you need to be very careful in this moment, because it's important for the you see the right hypogastric nerve in the presacral fascia. This is very important to maintain and to don't create any injury during the opening of the peritoneum and the presacral fascia. This is very important. You can continue with the exposure of the just opening the right pelvic side wall, because also in this step you can create some problem of the hypogastric nerve. You can see, you see, carefully, you need to dissect and to pose laterally to avoid any kind of injury in this sense. And then we can go faster. You can arrive until the uterosacral ligament. This is another important step for the nerve sparing, because in proximity of the uterosacral there is a lot of nerve. You see, there is the hypogastric nerve and beyond the ureter, and then you proceed to the dissection of the rectovaginal space, and you can continue until you reach the both levator ani fascia, you see, in right side as well in the left side, and you have a limit on the perineal body, because the perineal body is in the center is the limit of the dissection. It is clearly visible, you see, in the blue. Yes, it's color in the blue. Then you proceed toward the anterior compartment, and until you reach the bladder neck, and then you need to stop and just to place the fascia at this level, and then you can continue. You can continue just fixing the mesh, and then to the longitudinal ligament. With you can fix the longitudinal ligament with the stitches or with a protac. These are some paper in which they demonstrated that with the nerve sparing you can have the reduction of the onset of bowel symptom that can arrive in the traditional way up to 50% after sacrocolpopexy. And this is, I think, one of the future, and emphasizing the future technique. Now move to the laparoscopic lateral suspension that has been proposed by Dubuisson, that is a gynecologist from France, now living in Switzerland, due to some kind of difficult patient, which there was a difficult anatomy to approach, because you need to consider that this kind of technical procedure is a high level of difficulty compared to also to the other laparoscopic approach. And in those cases, Dubuisson proposed the lateral suspension is to place a mesh in the vault of the vagina, or just anchoring the cervix of the uterus and anchoring to the lateral side wall. And he published a first paper on 13 patients with 17 failure of the patient with a kind of reoperation, and 5.5 of erosion. And this is some kind of a literature, but we need to say that there are no long-term follow-up, as well as the traditional sacrocolpopexy, and also the number is very reduced. Just recently, a group of Italian colorectal surgeons, they proposed the POPs just for recovery of the prolapse, mainly related to the posterior compartment. And this is the conclusion of the most recent paper by Dubuisson and colleagues, that the laparoscopic sacrocolpopexy is the treatment of choice, but as an alternative technique, where the excess of promontory is difficult, for instance, in case of obesity, adhesions, sigmoid megacolon, or low position of some deviation of iliac vein. So it also feasible for surgeon of moderate experience. Now we move to laparoscopic pectopexy. The laparoscopic pectopexy has been presented also recently, just anchoring the mesh to the iliopectineal ligament, the Cooper ligaments, as the birch, and has been proposed with one non-absorbable stitches, you see, is like the lateral suspension, and this is the covering peritoneum, and the NICE did evaluation. These are the study presented on the NICE evaluated group from Germany, 83 patients. The second study by the same 83 patients in 2013. Group of 12 patients, 7 patients, and 1 patient. These are the 5 studies that evaluated the NICE, and these are the literature mainly in Brazilian and Turkish publication. But the NICE put some validity because there were no reports from UK, most published in Germany. All the published studies at small sample size with none of the studies with a mean follow-up longer than 2 years. And there was no blinding in the randomized clinical trial. And the recommendation is the current evidence on the safety and efficacy of laparoscopic pectopexy for apical prolapse is inefficient on quality and quantity that should be reserved for in context of research. So there are some critical issues of laparoscopic approach. One is the learning curve, because it's a difficult procedure, the learning curve is quite long. And this is a paper published by a group of French gynecologists in which the turning point is at least 18 to 24 procedures, but you see that the challenge of the implementing laparoscopic sacrocolpopexy, for instance, there is a 15-hour for suture training, but 30 cases at least, as well as 60 procedures for dissection. So the conclusion was that the large number of patients required for surgeon training is for relative infrequent operation create a problem, limiting the number of centers available for training surgeon. There are another critical aspect about the anterior compartment. This is a Delphi methodology that was questioned to the Italian Urogynecological Association, questioned to a group of experts in Italy of the laparoscopic surgeon, which defect correction is least satisfying for you in colposacropexy, apical, anterior, or posterior defect. And the majority said that there is no problem on the apical, while a big problem on the anterior defect, as well 30% on posterior defect. And also this is a paper on long-term outcomes of laparoscopic repair for cystocele, and 30% at the further cystocele repair procedure. So the conclusion was the long-term follow-up of laparoscopic cystocele repair showed that cystocele are the more difficult problem ready to repair successfully. And this is again the paper we publish on the anatomy, and in which you see clearly that in anterior vaginal wall, you can place the mesh up to the bladder neck, while posteriorly you can go more deeply. This is the reason why there is the critical aspect of the cystocele recurrence. And this is the reason why the group of Peter Dietz, the apical support have a little effect on the support of the anterior and posterior compartment, and more distal the mesh is placed in the anterior compartment, more likely it was for prolapse to recur in the anterior compartment. And finally, we reach to the robotic sacrocolpopexy. That is a natural evolution of the surgery from laparotomy, laparoscopy, into robotic. There is a huge opportunity for a gynecologic as well as urologic field to expand the use of robot on pelvic surgery. They take name from Italian world genius Leonardo da Vinci, and has several advantages, as you know, as a surgical robot and surgical consort. there are finger tip simulation, maintaining the same maneuvers of traditional surgery, able to reproduce hand movements, and the computer enhanced the precision with the possibility refinement with hand movement from 5 centimeters to 1 centimeter with the disappearing of digital tremors. This is the reason why there is a terrific similarity between the normal hands with the 7 degrees of freedom compared to the laparoscopy that has only 2 degrees of freedom. And there is another important opportunity for training about with the dual console, you have the possibility of teaching the young generation of surgeons. This is another example of robotic surgery that with sacrocolpopexy that is similar to the laparoscopy. Which is the difference? The difference is that with a robot, you can approach more deeply and more precisely all the plane, just doing the same nerve sparing procedure more precisely. But in case of, for instance, of difficult case, in case of recurrence or in obese patient, you have the more feasibility, the more facility to perform the procedure. I would like to go faster because it's the same maneuver as the traditional one. For instance, when you approach posteriorly, you can go deeply as well as you can go, and sometimes also the tools, the instrument of assistance, they can reach as deeply as you can go with the instrument, because it's you see the dissection is very easy and very efficient to perform any kind of plane. And this is as well as the other part, and also the dissection. You can create the two plane for to fix the mesh. This is the rectum and the perineal body, and the place where you fix the mesh that can have the obviously the possibility to work in a very more efficient way, avoiding as much as possible a direct contact to the vaginal wall. I would like to go faster because they are the same situation. This is in the anterior vaginal wall, this dissecting the bladder and arrive up to the bladder neck, and you can see the balloon or the Foley balloon just clearly. This is the level where you need to stop. In yellow, you see the balloon, and in the violet, you see this is the point. And finally, you fix the mesh. You fix the mesh bilaterally from one side to another side, and then you can go also to fix the longitudinal ligament. You can do with the stitches, or like in this case with the stapler that can have the same situation. You see, with the ProTac that have a faster and a system without any kind of problem. Go to the robotic, which is the learning curve is obviously reduced. The proficiency is after 25 cases and the efficiency after 36 cases. And comparing the ergonomics of surgeon from laparoscopist without robotic with robotic. You can see there is a statistical difference in terms of pain of neck, shoulder, back, wrist, knee, or arms from the different surgeon. So this is one of the other advantage. But as obviously, one is the cost. The cost, because the cost of the robot is more than 8,000 compared to the laparoscopy that is 7,000 and the abdominal 5,000. But this is a very interesting paper. If you distributed the cost over 60, 40, or 20 months, you see the cost decreased dramatically from 1.7 from a patient to 500 for patient. This is another interesting paper published the group of female urologists, Jennifer Anger from the US, in which he demonstrated the cost comparing laparoscopy versus robotic. And you see there is 11,000 for laparoscopy and 19,000 for robotics. But if you exclude the cost of the machine, the costs are quite similar. So that the message is that if you, an hospital or a university, buy a robot, should work as much as possible. Also 12 hours or 24 hours, because much does it work, much less is the cost for the procedure. About the results, comparing the robotic versus laparoscopy, several systematic review, they compare the anatomical outcome and all the other parameters, and they are quite similar and or slightly in favor of robotics compared to overall complication, the length of stay, or estimated blood between robotic and laparoscopy sacrocolpopexy. But for instance, one of the peculiarity of the robotic is, for instance, in the obese patient, because, for instance, in US, this is one of the more common population. And you see, this is very interesting paper that in case of obesity, normal weight versus overweight versus obesity, there is no difference in operative time and other parameters. That means that robotic make really the difference. So in conclusion about robotic, we can say that there are some pro, like obese patient, difficult anatomy, or recurrent cases. And obviously the cons are the cost, considering if we have a high volume center, probably this side effects can be reduced. So in conclusion of my talk, which is the future of surgery? This is one of the proposal. The operating room without humans could be possible. Nowadays is already done, because there are some proposals, for instance, from radical prostatectomy that can be performed without directly hands of the surgeon, but with a computer and with a robot. So I think probably it's a futuristic approach, but probably in the future. And our future, which would be, someday robots will do our job. What we do then? Probably we clean the robots. Thank you. Thank you for your attention.
Thank you very much, Mauro, for this very informative and very nice overview on the subject. I think we can have some discussion. I encourage the participant to send questions. But in the meantime, John, you have some question for Mauro?
Yes. We have several questions from the people that are very interested in listening to you, Mauro. There's one from Frankie Bates, who's an ICS nurse also from Canada, and she wants to know how the recovery is of robotic sacrocolpopexias with respect to pain.
There are some controversial about pain, because there are some paper, mainly, for instance, from the paper from, I remember, from Paraiso, Maria Paraiso, that says the pain is worse after robotic sacrocolpopexy, robotic procedure, compared to the laparoscopic procedure. But in our experience, we have a lot of experience about robotic as well as laparoscopy. In our experience, we haven't such kind of pain, or we have less pain compared to laparoscopy, because, for instance, in laparoscopy, mainly in difficult cases, because this is a very difficult procedure, you can need to force on the trocar. So sometimes the pain could be much stronger. So in our experience, I think the classical question, if you have your mother should be operated from a sacrocolpopexy, would you prefer laparoscopy or robotics? There is, for me, no doubt, absolutely robotic.
Okay, and is it possible to compare it to vaginal approaches? The pain, recovery?
Yeah, as you know, the vaginal approach, the pain could be higher, and there are some papers again compare the pain after a transvaginal approach compared to the robotic or laparoscopic approach, and sacrocolpopexy has at the maximum the less pain, and also in the long term less dyspareunia. Why? Because we didn't open the vagina, and this is absolutely mandatory for the prompt recovery and from healing process that reduce the creation of scar tissue that create pain.
Mm-hmm. And a question from Fauzi Farak: is it possible to combine a robotic or laparoscopic sacrocolpopexy with anti-incontinence procedures?
Thank you for the question. This is I didn't want to, because the question of incontinence, as you know, is one of the controversial, the hot topic of the procedure on sacrocolpopexy. I think we have two separate items. One is the anatomy. Another one is the functionality. You are a functional urologist, and you know very well that sometimes after the simple reposition of the anatomy, there is a reduction in terms of incontinence, and there are some studies, some debate in if the opportunity to make a contemporary reconstruction of the anatomy and combine the treatment of incontinence. I would suggest that if there is no a symptomatic stress incontinence, to postpone the procedure, just obviously with the adequate counseling with the patient, because there is a possibility that with a simple reposition of the anatomy, there is a disappearance of the incontinence, and we don't need to forget that mainly in elderly patient with severe pelvic organ prolapse since a long time, the detrusor is very weak, and sometimes there is a difficulty in empty the bladder. So I think it's wiser to wait all the healing process and then to reapproach the incontinence 3 months or 6 months later.
Okay, there's a question from Dr. Marianne who's asking whether you use specific mesh material for the robotic approaches.
Obviously now we are far from the traditional material. Polypropylene type 1 is obviously the optimal material for any kind of reconstructive surgery, but actually there is the lightweight material. The lightweight means that is 18 grams per square meter, that it's feasible for any kind of more physiological healing process, and I would suggest a soft material, ultralight material, because it's absolutely enough. There is, as you know, a great debate on how to fix the material with absorbable, non-absorbable, in the attachment of the vagina or in the levator ani fascia. I would prefer the non-absorbable material, even though there are some surgeons that would prefer the long-term resorbable material like the PDS. But
Okay.
depends on the experience, as well as in the longitudinal ligament that you can fix it with stitches or protect.
Yeah. One more small question, David, and then I hand over to you.
Yeah. Again, go ahead. Sorry.
Yeah, there is a question from EAU head office here, Mauro.
Yes.
They ask about economics, whether it would be advisable to centralize these procedures in one hospital in order to reduce the number, the cost of the robot.
Exactly. I agree completely, because I show clearly in the two papers about the cost, but as I mentioned before, you need to allow the machine, the robot, work 24 hours a day, if possible. So centralize the cases in a big center with a high volume center. It's absolutely ideal, because in this case you can reduce the cost. But I think there is no doubt that actually the laparoscopy in a traditional way, it's obviously less expensive than robot, but probably as all the high technology instrument, the cost we will reduce in the near future, and probably we will assist to a more advanced use of robot in any kind of pelvic surgery.
Okay, thank you very much. David, go ahead.
Yeah, Mauro, in the scheme you show on regarding the fixation of the mesh, the mesh doesn't reach all the vaginal length, and this when we talk with some other colleagues, it's common to say that gynecologists do not fix the mesh enough down into the vagina, into the pelvic floor. And why we urologists do it, we like to fix the mesh at the ani elevator. So would you comment on this?
Thank you, David, for the question. Is extremely important in this concept. It's really important that in the anterior compartment, as I show in our study, we cannot go deep than the bladder neck. So this is the limit. We cannot go deeper than the bladder neck. And this is one of the reasons why, for instance, in the anterior compartment, there is the risk of cystosis recurrence. In the posterior vaginal wall, you can reach down up to the perineal body. And there are two different schools. One is to fix directly to the vagina. And the other one, as our group, our experience, to fix laterally to the levator ani muscle. Why? Because this way we reduce as much as possible the risk of dyspareunia. But I would like to tell you, to emphasize the concept about, for instance, the lateral suspension or the pectopexy. The two procedures, they fix it mainly at the apex of the vagina, or the vault of the vagina, or the cervix, leaving the anterior as well as the posterior. And this is not good. This is important because the risk of recurrence is higher, less material you place between the bladder or the rectum and the vagina.
Yeah, regarding how to select patients, We know that the abdominal approach, either laparoscopic or robotic, provides better efficacy in the long term, but the complication rate is higher than the vaginal approach. So my question is, how would you select the procedure, for example, for a very elderly patient who is in a good shape to undergo either vaginal or laparoscopic?
The elderly is a great point of inclusion criteria, because the laparoscopic or robotic approach is mainly related, as I mentioned in the indication, is the young patient with they would like to have a sexual active life, and also for cosmetic appearance, because it's very important, because now there is also the possibility is emerging the concept of the make only a simple trocar instead of multiple trocar, because the cosmetic appearance is also important. For elderly patient, probably is more feasible to perform a vaginal surgery, vaginal recovery of the prolapse. In case of recurrence, in case of also elderly patient in a healthy situation, you can do laparoscopy or robotics, but you need to consider that you have a ideal situation on metabolic, for instance, cardiovascular system, etc., etc., etc. So I think the indication is mainly the anatomy. That means a high degree prolapse or vol prolapse after hysterectomy, and symptomatic obviously patient. But the difference is also to ask patient, because you do prefer to have more sexual life, or you don't care, because there are some patients, they said, I don't care. So obviously the transvaginal approach is faster, is less expensive, and even though the results sometimes are not so good, but it's absolutely a good option for that.
John?
Yes, Mauro. If you do a robotic or laparoscopic approach, you use mesh. So that's artificial material. We know all the discussions about how dangerous it can be, how difficult it is to remove it. First question is, if you have to remove it, is that also possible with a robot?
Yes, absolutely, 100%. And there are some times in which there is a detachment of the mesh from the promontory, and you leave all the mesh attached to the vagina, and you make a new attachment to the promontory, or vice versa. If there is a strong connection in the upward, you can create the tissue from in the bottom part of the vagina, and you fix it again. So there is no. This is one of the more proficient cases. I did just a few months ago one patient in which there was the mesh that was eroded into the bladder, and she did a sacrocolpopexy, and with the robot I entered the bladder, and was very easy to reach and to remove the erosion of the mesh, and to recover. It was very easy. So I think the robot has a great facility, and also in terms of teaching to the new generation of surgeon is much better, because laparoscopy, as I mentioned, the laparoscopy is a very difficult procedure. Is not for a middle skillful surgeon, but for high skillful surgeon. So it needs a long-term learning curve.
Yeah. And what would be an indication, or what are the indications to go in again with the robot and to to remove the mesh or release it or put it in another place? Is that pain or is it also function?
That depends on the patient request. The patient request, because if the patient has a pain, probably the best solution is to remove the mesh. Sometimes, as you know, it's very difficult to remove all the entire material, and it's more wiser to leave a part of the material itself. But you know, this is the main indication about the functionality. Considering all the different, because I do vaginal surgery as well as a robotic surgery. Combine the two field of surgery. I think that the transvaginal surgery has the higher case of pain compared to the abdominal laparoscopic approach. So I think this is one of the side effects. In terms of the functionality, as I mentioned, the abdominal laparoscopic approach or robotic approach leave the lower urinary tract in a more physiological way. This is very impressive. It's very impressive. The patient also, the obstructed patient, that they urinate with the straining to push down. They after abdominal approach, they urinate very easily, just because there is no obstacle to the bladder neck. This is very important.
Yeah, David.
Yeah, going back to the question of one of the participants regarding the correction of incontinence, you mentioned that you rather prefer to wait and see. But if the patient is clearly incontinent and you know that you should perform some anti-incontinence procedure, what would you do at the time of sacrocolpopexy? Would you do a tape after that, or using the same approach to do a birch?
You know, the more common, more physiologic way to approach a patient with incontinence, a combined procedure, is to make a birch. The birch is in the same field of surgery, so there is no risk. If I may report an experience of a great surgeon, laparoscopic surgeon, Arnaud Vattier, French Arnaud Vattier. When he does laparoscopic sacrocolpopexy, he finished the procedure and then he do a TOT or TVT. This is a different option. I don't know, because there are no until now there are no comparison data, study, a randomized clinical trial saying that if one procedure is better of the other one. You know, there are some, as I said before, there are some discrepancy on a critical aspect. I think one of the more important thing is don't create too much obstacle to a patient with previous severe prolapse, because as you know, as a functional urologist, you know, the bladder is very weak in those kind of patients. So we need to create less procedure with outlet obstruction. And in this sense, we can do or a birch colposuspension or a TOT, because TOT is more acceptable for the patient.
When do you decide to do, or how do you decide to go for a laparoscopy or robotic or a fixation to the uterosacral ligament?
The fixation of uterosacral ligament is, I didn't mention because the focus of the presentation is sacrocolpopexy. The uterosacral ligament is a new, very interesting approach, considering that using native tissue without any synthetic material, and could be feasible. And also the results are very promising. The only problem about uterosacral ligament, again, is on the anterior and partially in the posterior compartment, because you fix it with uterosacral only the apex, the level 1. You restore only the level 1 tissue. And this is one problem, because if you have a prolapse associated with the cystocele, with uterosacral, you cannot do only uterosacral, because in case of in the follow-up after 6 months, there is a recurrent of the cystocele or posterior vaginal wall descent. So uterosacral is very good. The risk is very low, doing in laparoscopic way, because you can see the ureter, so the risk of ureter kinking is quite near zero. But you need to take care also about the other compartment of the pelvis.
And regarding the concomitant hysterectomy, do you think that preserving the uterus really protects against mesh erosion in sacrocolpopexy?
Absolutely. There is no doubt. The data, I didn't present data about hysterectomy because we haven't time, but probably in another presentation we can speak precisely about hysterectomy. And this is another important point, important step, because hysterectomy is one of the key factor on the reconstructive surgery. If you remove all the uterus, the risk of erosion is quite higher, about can arrive, according to different studies, but can arrive up to 70%. So it's very high. Now there is a new trend. The new trend is to remove the uterus and to leave the cervix, for several reasons. One, because you preserve also the pelvic plexus near the cervix. That is one of the important steps. The second one, because the cervical ring, that is very important for the maintaining of the pelvic anatomy, and also because anchoring to the cervix is a strong part of the central body that can protect again a recurrence. So the trend is to remove the corpus of the uterus, the isthmus, and the body of the uterus, leaving the cervix that can maintain also the ability of the vagina, also for sexual intercourse, without avoiding to create a scar tissue of the apical colporrhaphy. And there is no risk of malignancy, because the risk of malignancy also in case of cervix is very low.
Okay, we are just coming to the end. So, John, do you have any other question from the participants?
Yeah, there's one more question from Monica Vici from UK. She's a urogynecologist, and she asked whether it's also possible to use autologous material for these procedures.
Excellent question. And I don't surprise that it was paid by an England colleague because they hate the synthetic material. But I agree. Yes, there are some new promising results. The original proposal I remember the group of Linda Brubaker that they had quite 30% of recurrence using the biological material. But nowadays, just last year, has been published a paper using biological material for sacrocolpopexy, and the previous results, the preliminary results are promising. I have a little concern about the long-term results, because you know there is a kind of autolysis because it's feasible, but the risk of erosion of this disruption of the and the maintenance of the tissue is higher. But it's at the moment is promising. Probably we need to follow this new field of procedures.
Okay, I think we are just about to finish. Any other comment, John? Mauro, I think it has been a great presentation. I think great discussion as well. Sacrocolpopexy is here to stay. It doesn't mean that all kind of prolapse has to be resolved with via laparoscopy or sacrocolpopexy. So the vaginal approach continues to be useful as well. My recommendation would be to do whatever works best in the hands of the surgeon. So, do you have any other comment, Mauro?
No, I think that the only comment I would like to make, first of all, I would like to thank all the colleagues and friends that they followed these new events, the webinar events of the ICS. And I think this is, for educational point of view, is one of the main steps of the ICS. And I'd be very, very happy to share the experience, because I think this is one of an important field, is an evolving field, and I think the ICS should play a pivotal role in the scientific community, because is not only, as I show you, is not only a procedure to put mesh, to put the stitches, but it is mainly a functional reconstructive surgery. And ICS is a functional society, and topics like this should be more and more emphasized.
Thank you very much, Mauro. I think that you are right. So the ICS has the capability and the resources to conduct online education, which is going to be more common in the next future. I just want to thank you again. Thank you, John. Thank you to all the participants for the question. And also I'd like to thank the technical team from the ICS office, because this has been a great webinar. Thank you very much.
Stay safe. Stay safe.
Stay safe.
Okay.
Thank you. Stay safe. Bye-bye.
Bye.
Bye-bye.